Okay, now how do we manage stroke? Stroke is a brain attack, it's just like a heart attack, but this is very serious. So what do we do with that? Could be we have different types of stroke. So if we wanna do based on the pathophysiology, could be thrombotic, could be embolic, could be hemorrhagic. So these are the things. And the pathophysiology and the patient, what does the patient present? Usually the patient present with focal neurologic deficit lateralizes to the lesion. Okay, so what causes the, let's open another one patient, let's talk about it here. Let's delete that. Okay, so the patient, what it could be focal, the present with focal neurologic deficit localized to the brain. Okay, so this focal neurologic deficit, what is that? If it's the anterior cerebral artery, this feet and leg, it's the anterior cerebral artery. Let me make it in one thing so that would be faster. So feet, leg. What if it is the middle cerebral artery? It's gonna affect hand, arm, face, and speech. What if it is posterior cerebral artery? It's gonna affect visual. What if it's basilar or vertebral? It's gonna cause syncope. What if it's cerebellar? It's gonna cause poor coordination. Okay, these are the important things that you want to know, and you want to know that the causes, risk factors, let's say here, risk factors could be due to vasculopath, could be AFib without anticoagulations, could be young female pain in neck after trauma, could be thunderclap headache, Cushing reflex, bradycardia with hypertension. So it's gonna be interesting. Like this is coma with stroke, could present this way. Okay. So let's do the general management and then we go to the different guidelines. So the general management for stroke, somebody, if you want to forget everything else, this one you gotta remember. The general management, what do? First, you want to do ECG, echo, and imaging. Okay. After that, you want to do meds, aspirin, statin. After that, vitals, you allow permissive hypertension, and then labs, you want to do A1C, you want to do TSH, you want to do lipids, you want to do CBC, you want to do CMP, and then ancillary, you want to do speech therapy, oral therapy, and physical therapy. Okay, so the first thing, imaging, EKG, echo, meds, aspirin, statin, permissive hypertension, labs, and ancillary. Don't worry about the spelling. Speech therapy, oral therapy, physical therapy. Okay, so this is the general. Now if we go to let's talk a little bit about that, the management in details a little bit. So after stroke, after you see the focal and neurologic deficit, what would you do? Stroke, focal neurologic deficit, you do non-con CT. Let's do it here. Let's bring that here. So you do non-contrast CT. After the non-contrast CT, you look for blood. Is there any blood? Look at positive blood. then this is hemorrhagic. What you do, you gotta decrease blood pressure, drip, and then you call the neurosurgery. They will coil, clip, and craniotomy. So these are the positive for hemorrhagic, positive for blood. What if there is negative for blood? Negative for blood, then it's ischemic. So that's the main thing that why we do. Now we gotta, after that we check, do we need TPA or not? This is important. Within 3 hours we give TPA. After, then we don't. After that, next day, what do? You want to do EKG for AFib, and if you found one, you want to do warfarin, heparin, or novel oral anticoagulant. Okay. If there is, and if you do echo for thrombus, if there is, then you do warfarin, novel oral anticoagulant, and heparin bridge. You can do that. And the other thing we want to do carotid ultrasound. If there is a stenosis, based on the stenosis, if it's less than 70%, we just do meds. But if it is more than 80 or more than 70 plus symptoms, then we do surgery, carotid and arterectomy, and stenting. So these are the management for the focal neurologic deficit. Now for stroke, could be acute or could be chronic. And the management for stroke, we gotta control several elements, okay? Like what are the elements that we want to see? First, TPA. Second, heparin. The third, anticoagulation, antiplatelet, and statin, diabetes, and blood pressure. Okay. So TPA within 3 hours or 4 hours, based on if they're based on the patient, their diabetes or any other complications. And we don't want to see no intracranial hemorrhage, bleeding, or surgery with TPA. Okay, that's the thing. Heparin, when do we give it? We give low molecular weight heparin if there's a thrombus. Okay. Anticoagulation, we usually for AFib. Antiplatelet. Okay. If it's acute, aspirin 325 if acute, and aspirin 81 plus diapyridamole or clopidogrel if chronic, like I had another stroke before. Statin, high potency for the chronic stroke. Okay, I had a history of a stroke, high potency statin. And diabetes, like on chronically, you want to do A1C less than 8. That's what we want to look for. Okay. On blood pressure, acutely, you give permissive acute management. Acutely, you just do blood pressure 220 over 120. But chronically, like over long term, you can manage it with AC inhibitor or diuretics. Okay, so these are the things for this circling that back. So for the TPA, mainly the only thing acutely we can do TPA and aspirin antiplatelet. This is acute. And control blood pressure 20 to 20 over 1. After the acute phase of stroke, we go to the chronic phase, which is low molecular weight heparin. Look for and give anticoagulation if there is atrial fibrillation or some cause that we need that. And antiplatelet, you can add aspirin 81 plus the paracetamol or clopidogrel. And you give them statin high intensity, control their diabetes and blood pressure. And that's basically the management of stroke. So in a summary, if everything fails, that's initially acutely, this is what you want to do. Imaging, EKG, echo, aspirin, statin, and vitals, you'll have permissive hypertension 220 over 120, labs, A1C, TSH, lipid, CBC, CMP, ancillary speech therapy, oral therapy, physical therapy. Okay, over the long run, and you do CT scan. CT scan, if there is a blood, hemorrhagic, call neurosurgery. If there is no blood, then ischemia. After that, you consider TPA. Okay, after the TPA, you gotta look for other causes. EKG for AFib, monitor, you can even do that. And then echo for thrombus, EKG for AFib, you give warfarin. Echo thrombus, if there's thrombus, you give heparin, warfarin. If there's stenosis, and more than 70%, that's with symptoms, surgery, CEA, carotid endarterectomy or stenting. Or if it's more than 80%, you just do that too. Then chronically, consider anticoagulation, the AFib, antiplatelets, aspirin plus dibretamol, statin, hypotensive, diabetes, A1C less than 8, blood pressure acutely 220 over 120. And that's summary of the management of hypertension. Thank you so much for listening.